Welcome back to American Journal of Infection Control, Science into Practice. It's the podcast where infection prevention meets real life. I am Nicki.
And I'm Jess. Today's episode is for anyone who has ever been handed the infection prevention job description and thought, cool, but where's the manual?
Spoiler alert, everybody, there isn't one. And today we're diving into a brand new study out of Texas, variability in orientation and training among Texas infection preventionists and its impact on CIC preparedness. So that looks at how infection preventionists are oriented, trained, and, brace yourselves, prepared for the CIC exam.
And let's just say variability is doing a lot of heavy lifting here. But first, let's introduce our guest, Dr. Kayla Ruch. Kayla Ruch is an infection prevention and control leader and public health educator with experience spanning acute care hospitals, public health programming, and applied healthcare epidemiology. She currently serves as senior instructional developer for the infection prevention and control with the Texas Epidemic Public Health Institute at UT Health Houston School of Public Health, where she designs and delivers a multi-year statewide IPC training series and evaluates program outcomes for dissemination and publication. That sounds amazing. Dr. Ruch has presented her work at national and state conferences, including ID Week, SHE, and Texas DSHS. And her research includes IPC workforce development and training standardization, including orientation practices and CIC preparedness.
Welcome, Dr. Ruch. We are so glad.
Thank you, Nicki and Jess. I'm happy to be here.
Yeah, we are very, very happy to have you join us today. Welcome. So let's set the stage. Healthcare-associated infections, or HAIs, are still one of the biggest patient safety threats out there. And I know we've all heard the CDC estimates that about 1 in 31 patients, hospitalized patients, gets at least one HAI, which is roughly 722,000 infections and 75,000 deaths every year. Holy cow.
But here's the hopeful part. Effective infection prevention programs can reduce HAIs by up to 70%.
Which means infection preventionists, you all, we, are not nice to have. We are mission critical.
So naturally, we must have a standardized, well-resourced, nationally consistent training pathway for IPs, right?
Absolutely. And that's what we're here to discuss today with Dr. Ruch. So, Dr. Ruch, what motivated you to study orientation and training variability among infection preventionists?
That is an excellent question. So I learned as an IP, I started in acute care in Texas. And then during the pandemic, with the shortages of IPs, I went out to New York to help, and I went into long-term and skilled nursing, and then did a wave of COVID out there, and then went out to California for acute care. And by working through different facilities, from a systems-based to independently owned to county-based in different states, in different acuity, I saw and experienced that there's no traditional training pathway. And I not only talked to people within my systems, but other colleagues that I met along the way of how have you been trained? Was there a playbook? Was there standard orientation? And there wasn't. And then with my experiences during COVID, just kind of being thrown into it when it is, as you said, mission critical during the pandemic, it's so hard to know what you're supposed to do in a new facility, even when you are a standardized IP, because every facility does something different.
Yeah, so basically infection preventionists are expected to be experts in everything, but the training roadmap is just good vibes.
Yes, you're asked to oversee sterile processing, high-level disinfection, environment of care, Joint Commission requirements, OSHA requirements, construction, microbiology, isolation. You are responsible for the vast of the program.
Exactly. Yeah, I used to say that it was like somebody handed me a big bowl of marbles, and you throw them all on the ground, and they say, now go pick up the important ones. But you have no clue which one the important ones are.
Absolutely, especially when you're a novice IP and you haven't gotten your certification yet and you're still kind of learning. You have no way to determine what's important, what's not important. is this a priority, or can this be, dealt with within later in the day, maybe in a couple days, or it needs to be dealt with immediately talking to your leader in your C-suite?
Yeah. Well, let's talk methods. This study surveyed 128 infection preventionists across Texas, representing all 11 public health regions: urban, rural, acute care, non-acute. This wasn't just big city tertiary hospitals. And about 22% worked in rural settings, which turns out to be really important later. How were the IPs recruited for this survey, and why did you choose a survey-based approach?
So I chose a survey-based approach for kind of my PhD. This was part of my dissertation and a big chunk of why I wanted to come back. So I was looking at the feasibility and the financial component, being a PhD student, of how do I really survey this and created this. So that's why I chose the cross-sectional approach. It's easier methodology of just one and done collecting data. And it's a less expensive study, especially when you are a grad student and you do not have a grant supporting your research. So I recruited individuals throughout the study. I met with APIC chapter leaders all throughout the state. So being an IP by training and then being a part of my Houston chapter, because I'm located in Houston, Texas, I was able to present it there, and then networked and presented it in Dallas, and then in Beaumont, and in Austin, and asked for connections in El Paso. So trying to get the big regions. And additional training that I had done at the School of Public Health networking, I had other IPs that were partaking in different training for foundational infection prevention and control education. So then I distributed the survey to them as well. I also put it on like open forums of like LinkedIn and like our Texas IP kind of pages, and then use snowball sampling, which is you send it to someone and they might know someone in that same network, so pass it on. So I asked other IPs to pass it along to their colleagues within their systems. And since I had worked in Texas for a year and a half, I knew people in different systems, and also tapped into my systems network of Memorial Hermann, Methodist, Baylor Scott and White, some really big systems that we have here, and then networked it that way as well.
The benefits of networking. Love it.
Yes, I was going to say that a lot of I'm envisioning one of those little diagrams where all the little offshoots are coming off. So tons of links. So the survey was made up of 54 closed-ended questions and one open-ended question covering demographics, training practices, and the 8 CIC competency domains. How did you determine what content was essential to include, and what were you most interested in capturing?
That's an excellent question. So I first, since my background in my PhD is Epi, I wanted to ask all the demographic question of kind of just getting a taste of who is our IPs. We've done that with other series. So asking the typical demographic of your race, gender, age range, location that you're in Texas, because I wanted to see if there was a difference between urban areas, which is our very big Houston, Dallas, Austin areas, compared to our very rural critical access that might be up in Beaumont or Armadillo or those areas. I then looked at the competencies for the CIC and asked 8 core components of how were you trained in these different parts. And I modeled some of my questions off of previous studies that I had seen from the APIC Mega Survey and then independent research as well. So I wanted to look at just who are our IPs in Texas? What do they look like? How are they being taught and oriented based on our certification exam? And then looked at different resources that are available to them that goes into that training. So such as, were you provided with the APIC text? Did you have the roadmap? Were you educated on Joint Commission, CMS, OSHA, ARRN, AMI guidelines? Were those texts available to you? And then the last question, I left it as open-ended just to have participants be able to share information or other resources that I didn't include in the survey. So it was kind of just an open-ended question that they could provide how they were trained or other resources they utilized to help prepare them for the CIC exam.
And so you also relied on self-reported rural versus the urban classification. Can you talk about how that decision might have shaped your overall analysis?
Yeah, so I already was thinking that we were going to have a lot of acute care academic in urban areas because in Texas, we have Houston, which has the medical center, which is tons of money, academic, very well-resourced departments, and very robust departments. Some of them have 6, 10 IPs, which are very large departments, and they are responsible for, a 600, 1,000 bed facility. And then Dallas is also big for medicine, and then Austin as well. So kind of really big, 3 main big areas, but we have a lot of rural critical access hospitals here in Texas, especially in West Texas, where it's very, very rural. They might not have an ID specialist. It's that ER or it's the ER, and then they get ambulance or helicopter flown into one of the bigger cities for additional care. So I wanted to look at that. I didn't want to put a specific area because some people commute for their jobs. Maybe they live in Houston, but they work out in more rural areas or more like northern Houston. And some people will define northern Houston as its own city versus in the Houston area. So just for ease and simplicity, since I wasn't being able to interview the participants, I wanted to be able to capture what they thought of. But looking back, I should have put more of a number to really define it to help reduce some confounding and some variability of what, with the self-reporting bias of what they considered rural and urban versus what I considered too. So that was something lesson learned that I should have been more specific on that question.
It's really interesting, though. And so let's talk a little bit more about the results, because some of these findings really resonated with me, and I'm sure with Nicki as well. More than half of the respondents felt that their training did not adequately prepare them for the CIC. And I would probably have been one of the respondents that felt that way.
Agreed.
I was surprised, but also wasn't surprised because I've been in health systems. I had a really good not onboarding experience, but I had a really good mentor. My onboarding experience was I had a director for 3 months when I was a novice, and then I was left alone by myself. And I was in charge of a 425 bed hospital, level 2 trauma center, and we had a pretty good sized NICU as well. So I was in charge of a lot of things and did not feel that my onboarding process really prepared me for this. And when I've talked to more people at APIC and at our local and national conferences and networking with them, a lot of people have said they learned by fire and not in the best way. So I wasn't surprised, but I was glad that my study showed my hypothesis that a lot of people are not prepared to do their job well.
Yeah, and more than half reported no standardized orientation checklist, which is kind of like being handed the keys to a plane and being told, good luck, go watch YouTube. So how were these IPs preparing for the exam?
So that's an excellent question. And that's in this study, I specifically asked them how they were preparing. So in one of my tables, in table 4 in the paper, I asked, how are you trained in the 8 core components? And it talks about formal education, which I defined as your secondary degree. So if you're nursing or your master's, that fell into that category. If you were self-taught, if you had professional development and training, which kind of looked like a seminar or a study group, or on-the-job training or other, to try to capture those areas of formal, self-taught. And when I looked at how those 8 core components of identification of infectious disease, surveillance, prevention and control, there was pretty much a mix between our self-taught and on-the-job training. So it sounds like from those results, it was close to 50-50. You were kind of taught it, but also there was this not expectation, but this self-taught driving because you did not feel like you were getting exposed to these topics and you had to kind of learn on your own, maybe do some your own reading. And that led into my other table 3 of asking them what resources were available to you. Because I know in some hospitals from experience and talking with colleagues, the APIC text is bought for them and provided, and their organization covers their APIC membership, and others don't. And same with the cost of the CIC exam. Sometimes it's the organization will pay for it. Sometimes they will reimburse you, or sometimes that financial cost is up to the IP themselves.
True. That is so true. So basically, this is a trial by fire. Mm-hmm. Another striking finding was that the rural-urban disparity, and as we mentioned, and that IPs in rural settings were nearly 3 times less likely to be CIC certified. What do you think is driving that? I mean, in my mind, I'm thinking you kind of mentioned more resources, more money, but what do you think?
I think it's a resource and money, also time, because in rural setting, I'm hypothesizing or kind of guessing that they're solo IPs because it's a rural setting, it's a smaller, and they might be tasked with many other things, especially if it's a very small hospital. They could be, the director of nursing, seeing patients, triaging, responsible for occupational health and IP. They're the multiple hat where they don't have time or energy to really commit to certification because they don't have protected, time. They can't go to seminars, or there's no money for them, or because they're responsible for so much, they don't know what resources are available to them or even to ask their leadership for them.
Such a bummer.
Yeah.
Yeah, it's just not going to be, it's not going to be a prioritization at a certain point. This is not a motivation problem. It's an infrastructure problem.
Yes.
And your regression analysis showed that the use of the APIC Novice roadmap and APIC text significantly increased perceived exam preparedness, which is very important. But interestingly, even among those who passed on the first attempt, many of those had not used those tools. What's your interpretation?
I think it depends on what is, again, available to you. I could see if they don't know about it, because I've been in facilities and they don't have access to the APIC text for their IPs. I've shared some of the resources with them that I've had from my personal, but they don't have them, or they don't know they're available, especially if you're a novice IP. You're a novice solo IP, you have no idea that that's available. So I think there's that. I think also, depending on the text, it's a lot of information, but low clinical application. And some of those questions on the CIC are very application based. So being able to see in kind of their onboarding process and how much they know might be a biased kind of indicator that they might be more prepared or not, and they don't need to lean on those tools. Also, which this study didn't look at, but most of the time people fall into IP. It's not the first career choice. So they have their training and experience in other sectors that then they're pulling over to IP. So they don't need to rely on those resources because of their experience. Maybe they were at, the bedside for 15 years, and then they're going something different. Then they come over to quality or infection prevention. So they have a lot of those skills and that knowledge base already obtained, and then they don't need to use it, which the mega surveys and this study has also seen that most IPs do come from that nursing background. So you do have that secondary education taught in your clinicals and when you're precepting, and then depending on what unit you're on, you have a lot of those skills that will translate into IP later.
Yeah, I mean, that all makes a lot of sense as well. Coming from a laboratory role prior to infection prevention, I was probably one of those IPs that did not know what tools existed. And fortunately, although in a rural area, I did have a team at an academic medical center that was able to provide me with some of that information. But I know that that's likely not the case for a lot of our critical access IPs who are a team of one. But your paper also highlights programs like APIC's IP Academic Pathway and the Texas Epidemic Public Health Institute IPC series as potentially scalable models. Why do you think these resources aren't yet being consistently embedded into IP orientation and training?
I think, well, the IP pathway just came out last year, so it is new. And there, from what APIC has talked about and presented at their national conference last year, there are universities uptaking and developing different either certifications or pathways. And the APIC has been working on their pathway for a long time, and it creates educational structure for undergrad, graduate level, and a certification, which I think that will really help people get the foundations and more of that standardized education, especially if it's in a bachelor's, master's program or a standard certification or a certificate program. It's more structured compared to learning by fire. The Texas Epidemic Public Health Institute Infection Prevention and Control series that I've been running, it's a newer program. I started it as part of my dissertation action of, well, we know that there's not good training. Let's create this training, and how can we deliver it? And so I started out with, in 23, with doing 5 lectures, and then I expanded it to 10 lectures, and we did foundational to applied epidemiology to program development for infection preventions, to this last year in 25 doing system-based IPC. And then I've been working with CIVIC to get IPUs for the content so that people can use it, and it's free, available, and on the web. So I've written a couple papers on how I've developed the TEPHI program and how it has been scalable and how many people have attended, and not only just in Texas, but the last year in 2025, we had people registered from 49 out of the 50 states that attended the lectures in over 20 different countries. So not only just the US, but internationally, people are wanting more infection prevention and control training and education. It just might not be available to them.
That's wonderful. Wow.
Good synopsis. So no study is perfect. Let's talk about limitations. Can you walk us through some of the key limitations of the work and how listeners should interpret the findings? And looking ahead, what kinds of studies do you want to see to build on this research?
Yeah. So some of the limitations, one, how I developed my survey tool, there was a lot of missingness, which is when people don't answer all the questions, they maybe skip questions, which I should have built the survey tool differently to force a response. But sometimes when you force a response, then you have other biases that go into it. So if you allow people not to report, or if you force a response, there's a limitation. Like you mentioned, nothing's perfect. The small sample size might not be representative, especially that there was a large percentage of urban acute individuals. It might not be representative of the rural areas and kind of what's going on there. There was only around 20% of rural percentage of the sample, which that might be either underreporting or overreporting based on those individuals. Also, the big study design is that these are self-reported data. So you have individual bias. I might think I'm excellent or proficient in this, but I'm really not. And then you might have recall bias depending on when you went through your orientation training. That could have gone 6 months ago, or maybe that was 4 years ago. And maybe you can't remember if there was a standard checklist or not, but maybe there is one now, but you're not sure. So there are these limitations just by the study design. Going forward, I think it would be better to do kind of a longitudinal study, which means it's a long term and you follow. So a prospective, meaning going forward, that you get a group of new IPs that are just starting, like today is day one of their new jobs and they're in IP, and then ask them surveys and collect data over the first year or 2 years that they're through. And when they talk about, ask them how they are trained on this. How are you oriented? Do you have protected time to study? Are you just thrown in? How many IPs are in your department? Do you get just a select service line that you're responsible for? So for HAI workups, maybe you just do CAUTI, but you don't get to do CLAPSI, or you rotate through all of them. And then asking them more detailed questions over a period of time at multiple time points up until their certification, and then have them to help increase validity, have them submit their certification results to say that you have that secondary factor that it's not self-reporting certification, but you actually have documentation of certification. I think would be really interested, especially that just in the last couple years, we have all these new tools coming out, but people aren't aware or they don't have access. So it'd be interesting to see what's being used, what's not being used, or maybe what tools are no longer relevant and maybe need revamping.
So let's talk real world implications. If you're a hospital leader, administrator, or IP director listening to this, what should you take away?
I think the biggest takeaway is that really look at your program and see how you are onboarding your individuals. Do you have checklists? Do you have the APIC text? Are you using the roadmap? And if not, put that in the budget. Where can you get it? For a hospital expense, it's not that big to ask for this subscription of the APIC text, pulling those other documents that they can use and then building that in, and then making sure that your IPs are able to go through every department and they're being exposed to everything, especially, OSHA regulations, AMI regulations that go into your sterile processing, which then directly relate to your surgical site infections, your high-level disinfection process, making sure that you don't have outbreaks and recalls because there's been a gap in your scope processing and now you have potential exposures. And then along with your Joint Commission and CMS regulations too, so that when it is audit time or recertification time for your facility, your IPs are confident when they go into that interview that they know what to say, they know how to say it, they know what the regulation is, they can speak to the policy, and they can speak to their program.
So let's look at some of the solutions. We'll start to wrap up. I want to know what practical advice you give to prepare for certification.
That's an excellent question. I think, really, when you are novice, the first question within that month or two that you're hired on, your leader should be driving and supporting you towards certification. It should be talked about, especially when you're new, of looking at your 30-day, 60-day, 90-day, 120-day plan going into your year, of talking about how are we going to get you certified, especially that it's the expectation and kind of the benchmark within our profession of proficiency. So making sure you're having those conversations. If your leader's not having them, speaking up for yourself and saying, I know about the field. I know their certification. What resources are available to me? Does my organization pay for it? Do I get reimbursed? Is there incentive? Is it part of my job description? Because now some of the job descriptions say if you're a novice IP within X amount of time, you need to be certified. So if it's in your job description, what are they doing to get you there? And then asking protective time and making sure that if you're in programs that have multiple IPs, shadowing different IPs, especially if you have a multidisciplinary team, that someone comes from a lab background, public health background, a nursing background, pharmacy background, of really talking how they do stuff, because every IP has a different scope and expertise and just their way of thinking. You could get 20 of us in the room, and I can tell you at least we will see multiple different things and have different opinions about that. So, and then try to standardize it and create an outline or structure, especially that a lot of our day-to-day stuff, there are stuff that we should do daily, weekly, bi-monthly, monthly, quarterly, semi-annually, and annually, that also, we're structuring our training, but also like not being so rigid within, have a little bit of flexibility, because who knows, Joint Commission could show up tomorrow. So obviously you're not doing the stuff that you thought you were going to do today, but then still have that outline, being able to go back and assess of, hey, we've covered that, but we only partially covered that area. Maybe we need to spend more time. Maybe there's additional resources in coming up with internal metrics to ensure that people are proficient in those areas.
So the bottom line, I think, is, as we mentioned, IPs are being asked to carry an enormous amount of responsibility with wildly inconsistent preparation. Certification success, regulatory readiness, and patient safety all improve when training is intentional, not accidental.
Yes, because we're responsible for so many things, you have to be very intentional and very effective with what you're spending your time, and very efficient to really get all the things that we need to do and be exposed to them and do them with confidence, so that you're creating a safe environment for all of our patients and our healthcare workers that are working in that.
Exactly. So if you're an IP leader or an educator or an administrator listening to this, orientation's not optional, it's infrastructure. And if you're an IP who learned by fire, you are not behind. The system was behind you. Dr. Ruch, thank you very much for this very important work. Thank you for joining us. To the listeners, thanks for tuning in to another episode of APIC Science into Practice.
And if you enjoyed this episode, please subscribe, rate, and share it with the colleague who trained you by saying, "You'll learn it eventually."
Yes, until next time, wash your hands. And remember, infection prevention is a science, but surviving orientation, that is an art. And that's a wrap. Thank you for joining us today. We are Nicki Shore and Jessie Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
APIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology, with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at APIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other APIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.